Welcome to Pharmacy to Dose, the Critical Care Podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. Each episode, we summarize the available evidence, discuss controversial issues, and provide practical take-home points with a subject matter expert. I'm your host, Nick Peters, and wherever you are and however you may be listening, thank you. Now, today we are joined by a special guest and friend of the pod, Scott Dietrich. Scott is an emergency medicine clinical pharmacist with the University of Colorado Health based in Fort Collins, Colorado. He completed his PGY1 residency at Wake Med Hospital in Raleigh, North Carolina, and has since been practicing in the emergency department. He was gracious enough to lend his expertise on today's topic, PCCs for PharmDs. Scott, thank you so much for joining us today.
Thanks for having me.
Now, based off that introduction, it seems like you've spent time on both the East Coast and the West Coast. So which one would you say is your favorite and why?
I'm definitely more of a West Coast person. Growing up a little bit in Florida, I'm just not a big fan of the heat of the South. So now being out in Colorado, the weather is kind of perfect out here. And then we all have all the beer and mountains to keep me busy. So it's pretty awesome.
Yeah, that's kind of a perfect lead in here. So I'm sure you've done your fair share of kind of hiking on trails and in mountains. So for anyone who is visiting or just kind of wants to know, what would you say are some of your, favorite, hiking trails or mountain climbs?
Yeah, we have a lot of trails out here. We have 58 mountains that are called 14ers, which the peaks are above 14,000 feet. Those are pretty fun, but they're a really long day. They're pretty hard. So those are usually like a once a year kind of thing. But up near Fort Collins in the canyon, we have a hike called Gray Rock. It's like an 8.5 mile loop that goes up to the top of a decent peak. So it's a good one. It's pretty hard. But since it's only like 25 minutes away, that's probably my favorite one right now.
Now, the good thing when you go on like a hike or a climb like that is like however many miles you walk, that's how many beers you get to enjoy after. And I know Colorado, there's quite a few options. So what would be what's like a go-to brewery spot of yours?
Oh man, it's so hard because we used to go to New Belgium a lot, but they are apparently selling out right now. So Fort Collins is kind of in an outrage about them not being employee owned and selling out right now. So if I'm not going to go there, there's a little local one down the street called Gilded Goat that we go to a lot. And they have really good beer there, and the people are super nice.
Wow, that's kind of breaking news. That's not something that I had heard. When I think of Colorado, that's one of the things that I think of is like Fat Tire. So that is wow. All right, support local. I hear you. So today we're focusing on the use of prothrombin complex concentrates, or PCCs, and their use in anticoagulation reversal. But we haven't always actually been this lucky and had these agents available as treatment options. So how did we reverse anticoagulation pre the advent of PCCs?
So back in the day, the only oral anticoagulant we had was warfarin. So reversal was just simple vitamin K plus or minus the addition of FFP, depending on what the scenario was. Now,
the old adage says if it's not broke, don't fix it. So the inherent kind of next question is there's got to be some limitations with using FFP or vitamin K. So kind of what are those with reversing anticoagulation?
Yeah, so once it's ordered, it takes a while to actually get to the patient. They have to be matched to blood type, and then since it's frozen, you have to allow time for it to thaw to be able to be administered. There's a risk of volume overload in some patients, and you get the fun acronyms like trolley and taco. There's infectious concerns, and then overall, once PCC came out and they actually compared them against each other, FFP is just not as good. You don't get as much of an INR reduction effect, and it doesn't last as long as PCC. So, nowadays it's kind of an inferior product.
Do you think the intrinsic INR of FFP kind of contributes to the lower effectiveness compared to the 4-factor PCCs?
So, yeah, when you give, FFP, the more you give, the less actually INR reduction you get. So, if you give a few units, you can get, the INR down a couple points, but the more you give, the decrease you get is even less and less. So you would need just an absurd amount of FFP to actually get someone down to a goal of like 1.4. And that's probably why in the Kcentra approval study, they set their INR target at 1.3, knowing beforehand that FFP is probably never going to get there.
Yeah, and in hindsight, a really, really smart kind of research endpoint there. So before we talk about kind of where we are now with PCC products, kind of what's a brief history of them? You know, there's a few that have kind of gone by the wayside now, but you know, what was their initial indication and kind of how did we get to where we are now?
Yeah, it all started with a 3-factor PCC, which had 2, 9, and 10. It was originally approved for hemophilia B patients, which is a factor 9 deficiency. And then they started using it off-label for warfarin reversal. The first article we could find talking about this was from 1997, and they were using pre-PCC, and they were looking at against FFP. So they worked better than FFP. Obviously, the groups weren't that equal at baseline. It was a small study, but that's the first one we could find of them doing some off-label PCC for warfarin reversal.
And so then, from the 3-factor PCC products, then kind of came the 4-factor PCC products, right?
Yeah. So Kcentra, which is the 4-PCC we're most commonly seeing, that was approved in 2013. And then there's another 4-factor PCC called FEIBA. And the first study using that for warfarin reversal was all the way back in 2005. So that one was being used a little bit before Kcentra even came out.
And I think most of the episode, our discussion is going to focus around the 4-factor PCC products. Would you say that there's any kind of current utility or role for the 3-factor products?
So the 2016 intracranial hemorrhage guidelines that were put out by the Neurocritical Care Society and the Society of Critical Care Medicine suggested using 4-PCC over 3-PCC. That's mostly due to having better and more evidence with the 4-factor products. But in 2017, there was 2 new studies that came out comparing 3-factor and 4-factor PCC and actually showed they were equivalent. So there might not be that much of a difference between them, but I know most places aren't even carrying 3-PCC anymore. So, everyone's probably using 4-PC at this point anyway.
Yeah, that's what my health system's using as well. So I think to make listening a little easier for everybody, throughout the episode, we'll be using kind of the brand names throughout. I know, technically not preferred, but I think if we kept saying 3-factor, 4-factor PCC, I think, not only would Scott and I's tongue get tied, but I think it would be a little tougher to listen to. So when should we be using just PCC products in general? Anyone who is bleeding or just needs reversal of their therapeutic anticoagulation, or do we, are there some specific indications?
Yeah, I think we have a big role as pharmacists in factor stewardship to ensure that we're using these things properly. We need to reserve them for life-threatening bleeding events. So someone with a stable GI bleed, although they are bleeding, they're not really a good candidate for this kind of therapy. When you have emergent surgical cases, you kind of consider it a life-threatening need. But if it's a non-emergent case, you can always have, the talk with the attending, see when it's scheduled. Maybe you can just, hold the therapy. If it's warfarin, maybe you can just give some vitamin K and that'll kick in by the time they go to the next couple of days. So, trying to reserve these for life-threatening situations is important. For non-life-threatening situations, if you wanted to try and do FFP instead, that's a potential option because, those delays in time, things like that don't matter as much because it's not life-threatening. Then if you're trying to reverse like a DOAC patient, the only really option we have besides PCC is just waiting. So, if it's an emergency, you're going to be given it. But if it's not an emergency, maybe they have a surgery scheduled for, an ortho procedure, and the next day or two, you can withhold therapy, maybe not need the PCC. And then, if they do need PCC, you can at least time it to give it before the surgery. So you get that kind of a maximal effect when they're in the OR.
I think you make a really great point there, and something to kind of highlight is that sometimes all you need to do is start a discussion. So not being afraid to talk to, the surgeon or the team who is trying to order it, just to get an understanding of of what they're trying to do, and then is this the most appropriate option?
Yeah, definitely.
Now, much of the conversation that we're going to, moving forward, that we're going to focus on PCC is going to be for the reversal of anticoagulation. But what is the role of, PCC for non-reversal indications, such as, coagulopathy due to trauma or, liver cirrhosis?
So for cirrhotic patients in our health system, we do just 1,000 units of Kcentra, which seems like a good starting point if you're not going to use FFP. Interestingly, in September, there was an article published where they were looking at giving FFP to these cirrhotic patients, and they only found one of like the 54 people they actually gave it to had any improvement in their coagulation parameters. So I don't know if that's going to point people in the direction of not using FFP. So we'll see more Kcentra in that indication, but we do it sometimes, not as much up here in Fort Collins because we don't have as many liver people as down in Denver. But our dose of 1,000 units seems like it does a pretty decent job.
Now, do you administer that irrespective of if they've gotten vitamin K to kind of promote their synthesis, like the liver synthesis of their clotting factors?
Yeah, I mean, I haven't done a liver dose of Kcentra in the ER in years and years, but, you ICU people are so much smarter, you could probably shed more light. But, I think it depends on the goals. If vitamin K takes 4 to 6 hours to even kick in and start doing anything versus, if someone's bleeding in front of you and you want, some action now, I think, you could potentially do both. You could just give the PCC or, again, it depends on what the goals are.
Talk about action now. What about for trauma patients?
Yeah, so this is becoming more common. Unfortunately, some of the literature out there isn't super helpful. The same group in 2012 and 2014, they were using 3-factor PCC and were using 25 units per kilo. Both studies showed decreased blood product administration and faster time to INR correction, so that's good. But then in 2018, there was a study with 4-factor PCC. Again, they showed that it was beneficial, faster time to INR correction, things like that, but they didn't report anything about the doses that they were using. So since most institutions don't have 3-factor, we have 4-factor, we kind of aren't really sure what we should be dosing at. But, considering that a unit of FFP has about 250 units of factor 9 in it, 1 to 2,000 units of PCC is like 4 to 6 units of FFP. So, somewhere in that 1 to 2,000 units, maybe 25 units per kilo is probably a good starting dose if you're going to use 4-factor PCC in trauma.
And because when you're giving it for that kind of indication, it's kind of irrespective of what their INR is. So you kind of need to go at it with a fixed dose approach kind of. So I think that's a really good advice right there, kind of comparing the units in FFP to the PCC products.
Yeah, and you're not trying to like completely replace all the FFP in those trauma people. They still need the volume from the FFP. So you're just trying to get some in, get it in quicker, get it working quicker, and then the FFP that you're getting later can kind of catch up and fill in the gaps.
Yeah, kind of start working right away as all of the things you talked about with FFP, kind of the limitations really, you wait for those.
Yeah.
So let's focus on Kcentra, our 4-factor PCC product for a minute. I think the scorching hot research topic here is, weight-based versus fixed dose Kcentra for warfarin reversal. And for those who may be, less familiar, when we say weight-based Kcentra, it's referring to the package insert dosing, which is, based on the patient's weight in kilograms and the INR upon presentation. So it varies anywhere from 25 to 50 units per kilo, depending on that INR, with a weight cap at 100 kilos. So I think the first question here is whether or not you use or believe in fixed dose Kcentra, and if yes, kind of what's your standard fixed dose Kcentra dosing?
So yes, I am a believer in fixed dose, and our starting dose is 1,500 units for everybody.
Now, does that, you mentioned 1,500 units for everybody. Does the fixed dose amount, ever change?
So all of the good literature that's out there right now does not change. However, I actually, in my protocol, we do change. So for patients with a total body weight over 100 kilograms, or if their baseline INR is greater than 7.5, or if they have intracranial hemorrhage, we actually increase the dose to 2,000 units. So that body weight comparison is from a study by Klein. And they did a post hoc analysis which showed patients greater than 95 kilos were more likely to fail the fixed dose regimen. And then in terms of the INR, Klein, that same study also found if people had a baseline INR greater than 10, there was a 10 times higher failure risk. And then in 2012, Corsand, they analyzed their fixed dose protocol and found patients with a baseline INR greater than 7.5 were more likely to fail. So to try to mitigate failures in our population, we have those two caveats in there now. As far as the intracranial hemorrhage dose increase, that wasn't part of my proposal when this was submitted to P&T, but the neurology team wanted to mitigate failure, so they wanted to do 2,000 units instead of 1,500.
But for those of us who may, only used weight-based Kcentra, or maybe having a hard time convincing, the ED or ICU teams to start using a fixed dose approach, what would you say are some advantages to using a fixed dose regimen of Kcentra?
Yeah, so right off the bat, it's going to save a lot of money. Kcentra is not cheap. 3 or 4 studies now that have come out have shown when they compare cost per patient, it's about $1,000 less using the fixed dose protocol. The dosing is easier, especially if you just do 1,500 units for everyone, than having to get a baseline INR and figure out their body weight and things like that. Some studies have shown a reduced time to administration, as you don't technically have to wait for a baseline INR. If you know they're bleeding and the labs aren't back, you can just go ahead and give a dose. And then the last thing is there's potentially less complications with the lower dosing. So there was a case report in 2016 by Zemrak, and they showed for the patients in their system that got a dose between 35 and 50 units per kilo, they had a 15% complication rate. But when they looked at the lower dosing between 15 and 25 units per kilo, they didn't have a single complication. So, giving someone 50 units per kilo is definitely going to increase the risk for a thromboembolic complication when you're giving someone more in the 20 to 25 range.
And I think the strategy that you, or your protocol, having specific patients that receive a higher fixed dose amount, which is still going to be lower, likely than any of the weight-based dose they would have gotten. I think that may help with, adoption, or may help, bring people on the fence, who are on the fence, or, believers in weight-based kind of over to the fixed dose side of things. Now, yeah. Now, most, if not all, fixed dose protocols kind of give guidance for redosing. Now, when do you redose Kcentra? Is it based just on repeat INR, or could it be, radiographic or clinical findings?
Yeah, I would say it's a combination of both. Obviously we have an INR goal we're trying to get to, but there's situations where people are not at that INR goal, and we have effective hemostasis, and there's potentially times when someone's at the INR goal, you get a repeat CT, they're still bleeding, you might need to redose again. So, I would say it's a combination of both. You can't just use one in isolation and just think everything is fine. But getting that repeat INR after it's in is very helpful. The doctors are going to be the ones mostly deciding on when they're going to repeat the imaging, if it's, that kind of bleed or not.
Now, when do you order that repeat INR?
So our protocol has it recommended within 60 minutes after the infusion. Anecdotally, I've seen a nurse draw one 2 minutes after the Kcentra was in and the INR was down to 1.2. But, obviously that's not something we want to happen all the time. So we set ours at 60 minutes, just knowing that, it could be a little bit sooner, could be a little bit later, but hopefully within, 1 to 2 hours after the dose has been given, we'll have an INR result.
Now, does your management change at all for patients who present with an INR of less than 2 needing reversal? And I ask this because that weight-based table, it doesn't give any guidance if your INR is less than 2. But I think there are scenarios where, many would argue that they are still clinically, therapeutically anticoagulated up to a certain point and need something done.
Yeah, so, my protocol kind of says the same thing for INRs greater than 2, you do the fixed dose. So it's kind of like an off-label thing that I'll do. So there's one study that was in intracranial hemorrhage patients, and they all had an INR less than 2, and the authors gave a dose of 15 units per kilo, and they showed that was 95% effective in reaching their target INR of less than 1.5. So if I have someone come in with an intracranial hemorrhage, their INR is 1.9, I'll calculate that 15 unit per kilo dose and then compare it to our fixed dose, and then whatever's less, I'll use that one. If someone's not having an intracranial hemorrhage and they have an IR less than 2, kind of like we talked about, this could be a situation where you go and talk to the attendings and see if they even need to be reversed. That might be a situation where you can just, if it's a DOAC, wait it out. If it's vitamin K only, might be an option. So, just depends on what the situation is.
It's almost like you're creating a best fit line out of those two. That's really great. Now, a lot of people listening may say, okay, I'm hearing a lot of what, Scott is saying, or what he does at his health system, or maybe what some of the literature says, but what do the guidelines recommend in terms of, reversal of the antithrombotics?
Yeah. So those 2016 intracranial hemorrhage guidelines, they recommended weight-based dosing. And then the ACC guidelines recommended weight-based or a fixed dosed option. I like how they give some credit to fixed dosing, but the dose they chose was 1,000 units, which I don't really agree with. They said 1,500 for intracranial hemorrhage, 1,000 for any other bleed, but from previous literature, 1,000 units is not as effective as 1,500. All the more recent studies that are having really good results are using 1,500 units. So I would kind of ignore those recommendations and just stick with 1,500 units for everybody.
It is nice that it's kind of getting some headlines, or some face in the guidelines. It's just frustrating that it may be setting ourselves up for failure, right, with the doses that they're recommending.
Potentially. I mean, there's a randomized control study called the Proper 3 that I think is ongoing right now. I think they've started, but they're randomizing people to standard dose or 1,000 units for non-intracranial hemorrhage patients. So, when that one comes out, we'll have a better idea if 1,000 is good or not. But based on the type of patients we see here in America with, higher total body weights, potentially a higher baseline INR, I'm not very confident that study is going to be very positive with 1,000 unit dose.
Now, up to this point, we've talked about Kcentra and its use for reversal of warfarin. Now, Kcentra is actually FDA approved for the reversal of warfarin. So I think there's much less controversy in terms of its actual use for reversal here. But maybe kind of going into some murky waters here, and let's discuss FEIBA, or our 4-factor activated PCC product, and its use for the reversal of DOACs, or our direct oral anticoagulants. So before we even kind of get into the details a little bit, how does Kcentra differ from FEIBA?
Yeah, so both are 4-factor PCCs, like we said. They both have factors 2, 7, 9, and 10. But all the factors in Kcentra are in the inactivated form. And then in FEIBA, factor 7 is in the activated form, and the rest are inactivated.
So does that difference, the activated versus inactivated, does that translate into any kind of clinical outcomes or anything that we know of?
So clinically, there hasn't been anything showing that one is superior to the other. But when you look at the warfarin reversal literature, you can see that activated factor 7 kind of gives it a little bit more potency. The fixed dosing we've been talking about with Kcentra is 1,500 to 2,000 units. The FEIBA dosing is only 500 to 1,000 units. So you can see with that, it's about half as much dosing. And there's a similar efficacy in terms of warfarin reversal. So that little bit of activated factor 7 has a little bit more potency in terms of INR reductions.
Now, we just spent some time kind of, comparing fixed dose versus weight-based Kcentra. So we've kind of talked about that general dosing. But in regards to FEIBA, what's its kind of general or recommended dosing strategy when it's being used to reverse some anticoagulants?
So it depends on what you're trying to reverse. There's several studies showing that with warfarin reversal, there's a fixed dose protocol that you can use between 500 and 1,000 units. But if you're doing DOACs, the weight-based dosing at this point is a lot more literature behind it.
Okay. So we're going to kind of step into the ring here. So we have Kcentra on one side and FEIBA on the other, and kind of thinking about reversal of DOACs. So kind of starting the discussion with Kcentra, the kind of the 4-factor PCC product, and then we'll switch over to FEIBA.
So there's, I think, 4 studies worth looking at, talking a little bit about with Kcentra and DOAC reversal. First one was in 2017. It's the biggest one so far. There's 84 patients 70% of them had an intracranial hemorrhage. The dosing in the study was 1,500 to 2,000 units, which based on the weights they reported came out to about 25 units per kilo. And then they reported a hemostatic efficacy of 69%. The next year in 2018, Schumann et al., they analyzed 66 patients. Half of them had an intracranial hemorrhage. They gave 2,000 units to everybody. And then based on the weights they reported, again, it's approximately 25 units per kilo. And they showed a nearly identical hemostasis rate of 68%. And then this year we have two studies. The first was by Smith et al. They only had 31 patients. The dosing was 25 units per kilo in 38% of patients. Over half of them got 50 units per kilo, and then 35 units per kilo was in the rest. The hemostatic efficacy they reported was 81%. Unfortunately, they didn't extrapolate the results based on the 25 versus 50 units per kilo dosing, but actually reached out to Melanie Smith on Twitter. And she said that the two failures they had, one of them got 35 units per kilo and the other one got 50 units per kilo. So the failures weren't necessarily dose related. And then the last one in 2019, again, by Karen Berger, who you had on for the status episode, they analyzed 22 patients, all of them with intracranial hemorrhages, and all of them got 25 units per kilo. And they were able to assess the hemostatic efficacy in 19 patients and had a 95% efficacy rate based on repeat CTs with no hematoma expansion. So overall, the effectiveness is probably in the 70 to 80% range, with the larger studies having lower rates of, the larger studies had better or lower rates of efficacy. The smaller ones being 70, maybe into 90% range. So the true efficacy is probably somewhere in the middle of those there. But it seems like it works pretty well. 25 units per kilo would be what I would do based on the last study by Karen Berger too.
And it's not just that there's one study with this. You have almost like 3.5 studies looking at this, median dose of 25 units per kilo for these patients and finding these results, coming together. So that's definitely something you look for. Now, the hemostatic efficacy, you're throwing out, numbers of, 68, 69%. So how is that a good number? Because when I hear that number, I'm thinking, are we shooting for 100%? Because if so, I'm not sure this is working as well. Or am I kind of interpreting those numbers incorrectly?
No, that's a really good question, and something that comes up a lot when people are, discussing the literature and this efficacy. So, when we do warfarin reversal, the standard dose is not 100% effective. That approval study that got Kcentra approved was right around 69 or 72% effective. So, somewhere in the mid 70s is about what we're seeing over and over again in these studies with adequate dosing as in terms of effectiveness. So, these studies showing 69, 68%, maybe 80 to 90%, that's good. And it's, similar to what we would see with, other agents.
Okay, perfect. And of course, appreciate you listening. Appreciate the shout out to previous guest, Karen Berger. She's great. So we got Kcentra on one side, some, all things considered pretty decent data. And now we have on the other side kind of FEIBA.
Yeah, so there's unfortunately a lot less to go off of with FEIBA for DOAC reversal. In 2016, there was one study. They had 5 patients with intracranial hemorrhages and all got 50 units per kilo. They were able to show 100% of those did not have any hematoma expansion, but again, it's only 5 patients, so it's a little hard to extrapolate from that. 2017, there was another study, small with 11 patients. They gave everyone 20 units per kilo, but they were showing that 4 of those 11 patients had worsening hematomas on their repeat CTs, so their efficacy rate was only 55%. And then this year, the largest one we have so far, Dager et al. Had 64 patients. They had 2 dosing arms. They had a low dose group, which was around 10 units per kilo, and they had a moderate dose group, which was around 25 units per kilo. Of all those 64 patients, only 2 patients had a worse hematoma expansion on their repeat CT. So their efficacy they found was about 97%. So overall, it's really limited data. It's less than half the patients enrolled that we have with Kcentra. There's a lot wider range of dosing. There's a lot wider range of efficacy numbers. So it seems a little unclear whether it works as well or not. Even if it does work, what dose you should probably be doing. But if you do have FEIBA, I think a lower dose of like 25 units per kilo is probably a good place to start.
So kind of tying together what you were saying from both of those, my interpretation of that is that you probably lean towards using Kcentra for DOAC reversal. Is that true?
Yeah, I mean, there's just so much more data, more patients, more consistent results with Kcentra than when we have with FEIBA. So if I had to choose between the two, I would definitely go with Kcentra.
Now let's kind of switch gears just a little bit and, talk about Kcentra versus FEIBA for warfarin reversal. I believe kind of you specifically have a little bit of experience kind of looking into this question. Is that correct?
Yeah. So Sean Rose, a pharmacist up at the University of Tennessee, we did a study with standard dose Kcentra versus fixed dose FEIBA, where their hospital was using the FEIBA. My hospital was doing the Kcentra, and we compared them together. We didn't find any differences in the ability to reach a post-PCC INR goal of less than 1.4. And there's a small study. There were some appropriate criticisms that were, as an editorial in critical care medicine. But the results we found mirror the results seen in other studies in terms of efficacy. So jumping off that, we did another study that we called PCC War, and that was fixed dose Kcentra versus standard dose Kcentra versus fixed dose FEIBA. And we had 6 hospitals, 2 for each arm, and we got a total of 167 patients enrolled. We're still looking at the data a little bit, but last year we presented a poster at ACCP, and originally it looked like the fixed dose Kcentra was the best in terms of efficacy with about 76%, while the standard dose was the most effective. The fixed dose Kcentra and fixed dose FEIBA were only about 55% effective. When you start looking at the baseline numbers between the two, the standard dose Kcentra group had an INR of 3.4, and FEIBA was at 4.2, and the fixed dose Kcentra group was at 4.78, which is significantly higher. So that's probably why we found a difference between the two arms in terms of efficacy. But we're trying to, do some regressions and take things into consideration. And, hopefully by the spring, we'll have something to publish on this.
I'm looking really, really forward to seeing that, because this is great. And then I have to ask, I'm such a sucker for study names. PCC War, that's one of the best. And is that something that you created? Because it seems like whenever I create presentations, sometimes I spend more time trying to think of the great title than I do the actual presentation itself.
Yeah, I wish I could take credit for that one, but that one's Sean's. So he just came up with that off. I don't know why, 3 or 4 months after we were already into this, he's like, I had a great idea for the title. And we're actually doing another project with a reversal survey, and he came up with the name of Aries for that. So he's a title making machine.
Oh, this is great. And so now we know if anyone's stuck with trying to find a really good, research title or acronym, we know who to reach out to.
Yeah, definitely.
Now, should pharmacists or other kind of critical care practitioners be fighting to have both Kcentra and FEIBA on hospital formularies, do you think?
Yeah, I don't think that there's enough data out there to show that one is, definitely superior to the other. In terms of warfarin reversal, they're probably equivalent. In terms of DOAC reversal, the Kcentra might be a little more effective. So, if you came from the standpoint of having just one agent to use for everything, maybe you could give a slight nod to Kcentra because there's better data with DOAC reversal. But for the most part, I think if you have one, you have some studies to support your use of it there.
I agree with what you're saying about kind of Kcentra just having more data to support its use. Now, it also has more just literature in general for fixed dosing when it's being used as a reversal agent. Now, do you commonly use a weight-based or a fixed dose approach when you're using FEIBA? Because I've heard you kind of describe both.
Yeah, so All the literature so far with the DOACs is, weight-based dosing, but it varies very significantly between 10 and 50 units per kilo. So if you are going with off the literature, what you're doing is probably in the 10 or 20, 25 unit per kilo range. But I have heard of some people who are FEIBA hospitals that use FEIBA for warfarin that they just do about 1,500 units for their DOAC reversals, but there's not very much literature to back that up at this point.
And I think it's really hard to kind of talk about PCCs without discussing the extremely expensive and brand new elephant in the room, which is Andexxa or Andexxa alpha, kind of the reversal agent for the factor 10A inhibitors. Now, I think we could definitely have an entire episode just kind of breaking down Andexxa itself. But I think one thing that might be fun to do kind of in this PCC episode is kind of almost do like a pros and cons list, kind of like a little old school. So what would you say would be some pros or positives for the use of Andexxa?
So it's the only, quote, agent-specific DOAC reversal agent we have out there. So, Andexxa likes to say that they're that over and over. But otherwise, when the drug is infusing, there's a very high degree of drug binding. When you look at those Andexxa A and Andexxa R studies, when they actually give it, the anti-10 levels fall dramatically very quickly. So, it works very rapidly when it's given, and it's, specific for 10A. So those are some of the pros.
Now let's kind of go to the other side and kind of talk about some cons.
So, in my opinion, there's a lack of outcome data with Andexxa 4. They had a lot of exclusions in that study. So, the people we're reversing on a daily basis don't match up that well with people that were enrolled in Andexxa 4. I was talking about how rapidly it works, but the kinetics wise, it doesn't look that great. As soon as they stopped infusing the drug, the anti-10A levels rise very, very rapidly, and the patient's back to their baseline in about an hour to 2 hours. So that's kind of concerning to me. And then obviously, a lot of people talk about the cost of $58,000 per dose, which is, not a good thing.
Do we have any evidence to suggest that we could or maybe even should be using PCC agents rather than Andexxa?
Yeah, I mean, in my opinion, there's enough studies out there. We have enough patients, enough consistency with the results that I think that, Kcentra is as good, if potentially not better, than Andexxa for DOAC reversal.
Do you think, you highlighted some of your just general concerns, but I think, one question that really weighs on, I think, especially a lot of the administrators' minds is, do you think we'd be using Andexxa more if not for the cost? Because I think rightfully so, that's getting a lot of the headlines.
Yeah, we might be if it was the same cost as, Kcentra people would be using it more. But, I keep coming back to the kinetics. So, idarucizumab, which is the reversal agent for Pradaxa, is another similar drug that got a lot of flack when it was approved because there was no comparator in this study. But that drug completely and irreversibly binds dabigatran. And the binding affinity is 350 times that of the active site. So once the drug binds to dabigatran, it gets completely eliminated. Versus Andexxa, you give this 2-hour infusion. 2 hours later, the patient's back to their baseline anti-10A level, like they didn't even get it. So, I just need to see more long-term outcomes of, does this actually work? Or are you just reversing someone for 2 hours and then they go back to being where they were if they didn't even get it? And then, interestingly, an article just came out in Neurocritical Care in October that kind of highlighted that the FDA clinical reviewers originally voted to not approve Andexxa. As they said, the safety and efficacy data were not adequate to support its approval. But the director for the Office of Tissues and Advanced Therapies overruled those reviewers and got it approved, but with the caveat that an RCT had to be performed. So I'm sure Portola is going to take their time with that study, but we'll see what happens when that finally comes out.
I believe you wholeheartedly that we will be waiting waiting for a little bit. It'll be like the stress ulcer prophylaxis guidelines.
Yeah.
But you highlighted a really great paper for anybody who may be tasked with bringing this to PNT, or you're on the committee, or you just want to know more. But it was published in Neurocritical Care, and it's called Key Points to Consider when Evaluating Andexxa for Formulary Addition. So that, along with all the other studies that we've kind of been talking about, are going to be on the show reference list. So I encourage everyone to read, because until I read this article, I didn't realize that about the FDA approval and all of that. So kind of eye-opening in a certain sense. Now, hypothetically, and I'm of course not wishing this, I am profusely knocking on wood here. But if you were, receiving, say, Eliquis or Xarelto, and you had a life-threatening bleed, which reversal agent would you want to receive?
So at this point, I'm going with Kcentra at 25 units per kilo, based again on the efficacy numbers we've seen, cost savings associated with it compared to Andexxa. That's what I would recommend for a patient in my ER. So that's what I would go with for myself.
Putting your money where your mouth is. We definitely appreciate that. Yes. Now, do you all have Andexxa on your formulary?
Yeah, we don't have it at our hospital. The main hospital in Denver has used it a few times, but they're the only one in all of Colorado that I think that has used it. So I don't have very much experience with it. My health system has it on formulary. We have fairly strict restriction criteria, limiting it to just intracranial hemorrhages. They had to have, had their last dose within 18 hours, kind of similar to the approval study. And a couple of things that we have encountered, we've used it, I think, on 2 or 3 patients since it's been approved, is that compounding it in a timely fashion can be very challenging, because I know they're kind of moving away from the 100 milligram vials, but they have 100 and 200 milligram vial options for basically a fixed dosing strategy. And so I don't know if anyone's ever compounded like dantrolene in your emergency kits, but it's like you have 8 to 16 vials that you're reconstituting. It's not very easy to get into solution. So that was one encounter. And the second is that when you look at the administration instructions, you're supposed to start the maintenance infusion within 2 minutes after the bolus is done. Now you work in the ED, right? So tell me in a busy day how possible or how likely it is, without you being right there, that's going to get started within 2 minutes. You would have to have all of the stars aligned and 4 nurses in the room to have that probably happen.
And then, you bring up those kinetics concerns, all of that is kind of alarming, because that type of error, instead of a 2-minute gap, it's a 10-minute gap. That could be something that no one would ever know about, right? Because it's just the normal time course of being in the hospital and the meds. So those were frustrating things. For one thing that we did, I know some people put the bolus and the infusion in the same bag and just infuse it that way. And what we do is we prime 2 smart pumps. And then once the bolus runs out, they flush it with saline, and then they kind of start the other one up right away. So not a perfect solution by any means, but something that kind of works for what we were able to do. Now, what would you say is the role of pharmacists here? How can pharmacists kind of help with safe and effective use of some of these PCC agents?
So we touched on that earlier, but factor stewardship is a big role we can play. These things are expensive; they're not without risk. So pharmacists are on the front lines of ensuring that we're only using them in appropriate cases, which is a life-threatening bleeding event. Situations in which are not indicated, like a stable GI bleed or surgery in the future, have that discussion with the attendings, and maybe you can wait or even skip the dose. If the surgical patients find out when the surgery is scheduled, so we're trying to reverse a DOAC, you don't want to give the Kcentra and then have surgery 6 or 8 hours later. If you want to give it right before surgery, so it's maximally effective, if they're having their surgery in a day or 2, maybe you can just hold the therapy, and, by the time they reach surgery, they'll be fine. Another facet is to ensure the correct dose is ordered. So we want to avoid overdosing, as we know that we might increase the risk of thromboembolic events, but also it's very costly. So if you're overdosing someone, you're wasting more money. And then we want to make sure we're not underdosing someone. So we don't want to increase the risk of failure because we didn't give them enough dose. Among the patients with warfarin reversal, you got to make sure the vitamin K is ordered. That gets omitted a lot. Everyone's knee-jerk reaction just to order the Kcentra, and they forget that vitamin K. And if that one's not on board, you're going to have a rebound INR in 6 to 8 hours. So, it's a very easy intervention for pharmacists to make. And then again, in those warfarin patients, we really want to make sure that we have a repeat INR ordered to assess for its efficacy. You don't want to give a dose at noon and not have an idea if their INR is reversed until AM labs the next day. So that's an easy intervention, again, for the pharmacist to make.
I want to highlight something that you said about the vitamin K. I think that's really important just based on the kinetics you've talked about. Now, do we need to be giving this for anybody who needs reversed or just somebody who needs to be reversed due to bleeding?
I mean, if you're going to reverse someone with Kcentra, they need to get vitamin K, in my opinion. So, the vitamin K starts working in about 6 hours. The Kcentra is going to start wearing off in about 4 to 6 hours. And if you want their INR to be down for more than 6 hours, you got to give them both together.
Perfect. So Scott, you gave us tons and tons of information to kind of dive into and chew on later. But if you had to create kind of like a cheap cheat sheet or kind of a list of take-home points for us, what would some of those be?
So for warfarin patients, I like fixed dose. If you want more detailed information on that, I have a post on PharmD that kind of goes through my protocol, the literature behind it, and some more rationale of why we do that. Right now, the dose for everybody should be 1,500 units. You can consider increasing that for certain populations like I do. But, as of right now, there's 3 good studies out there showing good effectiveness with 1,500 units. Our health system is currently reviewing our fixed dose protocols. We'll have a year's worth of pre and post data that the stats guys apparently working on right now. So hopefully we'll be able to find out if those subtle dose increases are worth it or not. And then in regards to FEIBA for warfarin reversal, when you're comparing to Kcentra, there's no obvious winner at this point. So whatever your institution uses is fine. Just remember, if you're giving one, you have to give it with vitamin K. In terms of DOAC reversal, I think Kcentra seems like a better option than FEIBA at this point. There's more data, more consistent data with it. So I would go with that over FEIBA. If you have Andexxa, you're probably going to be using that. But again, Kcentra seems to be pretty effective so far in the retrospective studies. And I know we all want to see more data with Andexxa, and we definitely want to see that head-to-head comparison to determine if that $58,000 price tag is worth it. And then the last thing, us as pharmacists are on the front lines of factor stewardship. We play a big role in making sure these therapies are used appropriately and effectively. Kcentra, FEIBA, it's expensive. They're not without risks. So we want to make sure we're only giving them when they're actually needed. And when we do need them, make sure that the correct dose is ordered.
Kind of something to reemphasize is factor stewardship. Pharmacists getting involved on protocols and committees to really not only help the patients that they're actively rounding and seeing, but even some of the patients that they're not. So really, really awesome point, Scott. I appreciate it. And we're recording this actually on the week of Thanksgiving. So happy Thanksgiving, to you, Scott, and to the listeners. So if you had to pick your favorite side for Thanksgiving, I know we like to do the questions at the beginning, but this one just popped in my mind. What would you say your favorite is?
I think it's going to be mashed potatoes and gravy, but stuffing's a close second too.
That is all right. We're on the same team there. This is a
Good.
mashed potatoes and gravy podcast, so we're on the same side there. Scott, this was great. Really, really enjoyed gaining some insight, kind of discussing all things related to PCCs. So appreciate the time, effort, and energy. Now, where can the listeners find you? Are you active on any social media sites at all?
So I'm on Twitter, so you can find me under my handle at PCC_PharmD. You can follow me or send me messages, but that's the best place probably. I'm not on Facebook or anything like that. So Twitter is where it's at.
So obviously based on his your Twitter handle and the title of this episode come to you for all things PCC related.
There's other people out there who know more than me too.
Well, another huge thanks to Scott Dietrich for taking the time to join us today. Also want to give a massive thank you to you, the listeners. This podcast doesn't exist without you, and we greatly appreciate you in this time of giving thanks and Thanksgiving. So please send me feedback, both positive and negative, as well as any guest or topic ideas via Twitter or Instagram at pharmacy2dose, that's TO to dose, or via email at pharmacy2dose@gmail.com. On our website, pharmacy2dose.com, you'll find the show notes that include background reading, guidelines, articles referenced in the discussion, the post that Scott mentioned from PharmD that'll be referenced on there as well, and so much more. Honestly, I'd love to hear from each and every one of you. So until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.